Dr Ingram.
That's me.
You saw John?
Yes, I did see John today.
Okay, do you want to present your findings then?
Sure, thank you. So John is a 98-year-old man, previously living independently with daily services in place, who has been admitted to hospital with left lower limb pain secondary to likely slim ischemia. This is on a background of significant vasculopathy, including peripheral vascular disease, requiring previous femoral artery stenting, ischemic heart disease requiring coronary artery bypass grafting, and type 2 diabetes on insulin, complicated by a diabetic foot ulcer. His other active issues include a urinary tract infection treated with IV antibiotics in the hospital, and poor mobility following his surgery, placing him at a high falls risk and requiring ongoing rehabilitation. After discussing his disposition with his son, a decision has now been made for long-term residential care placement. I'll start off by his first major issue, which is his peripheral vascular disease and associated high falls risk. John developed acute onset pain and swelling of his left lower limb approximately 2 weeks ago. This was not associated with any fevers or rigors. His neighbour called an ambulance on his behalf and was admitted to ED for workup. This is on a background of previous peripheral vascular disease requiring what sounded like a femoral stent insertion. However, John's not aware of where the insertion was made approximately 5 years ago. He also has risk factors including type 2 diabetes. He is a non-smoker. Investigations this admission included a CT scan of his lower limb as well as a Doppler ultrasound. He is unsure about the results of these, but he was informed that there was occlusion of blood flow to his left leg. There was no DVT found, he believes. In terms of management, a percutaneous procedure was undertaken in his left groin to assess if there's claudication of the left femoral artery. He is unsure whether a stent was inserted. In terms of management, he was under the care of the vascular team for 2 days before being transferred to the rehabilitation ward. He's been on aspirin, which is a long-term treatment, and it was monotherapy, which likely suggests that he didn't actually have a stent insertion, as I would expect a dual antiplatelet therapy to be commenced. In terms of functioning, he's currently requiring 1 times assist with his mobility. He's deemed a high force risk, walking independently, and is walking around with the wheels in a frame with 1 assist. He's had a background of 1 fall last year. This was mechanical in nature whilst getting up from the toilet. There was no syncope involved at that time. After a family meeting with his son, a decision was made for residential care placement, which I'll talk about in the social history. His next issue is his type 2 diabetes with a diabetic foot ulcer. John was diagnosed with type 2 diabetes approximately 30 years ago during his admission for a myocardial infarction. Investigation at the time, he believes, was just a random blood glucose testing which revealed diabetes. He does not recall an oral glucose tolerance test. He's not aware of his HbA1c. Risk factors for his diabetes include family history of type 2 diabetes with his mum's side, but he just has no history of obesity. In terms of management, he was initially treated with insulin as an inpatient at the time, and this was transitioned to oral hypoglycemic agents. He's not sure which agent he was put on, and he was treated with oral agents for approximately 15 to 20 years before starting back on insulin 10 years ago. He was always on once daily insulin. He's not sure of the medication, but I do assume it might have been Lantus. Recently, he's been switched to Ryzodeg, and he uses a dose of 28 units in the morning. This is actually administered by Silverchain, who come in every morning to do his blood sugar levels and also administer the insulin secondary to his macular degeneration. He also gets a second agency to come in on the weekend to administer his insulin and check his sugars. In terms of blood sugar monitoring, he does not do this as mentioned, and he states that his sugars he thinks are pretty good, but he can't give me a rough range. He does believe that most of the time they're below 15. Again, he's not able to determine what his HbA1c is. He can't recall any episodes of hypoglycemia in the last few years. His current blood sugar in hospital was between 9.5 to 20.9. The highest reading was in the evening. He does get a podiatry review once every 3 months for his diabetic foot ulcers, which is currently being, at the time, bandaged and treated with distressings. He does not have any ophthalmology review, so he's not had any ophthalmology review for many years. His last ophthalmology review, he cannot recall, but he was previously reviewed for his macular degeneration also. In terms of microvascular complications, there's been no history of diabetic retinopathy, but again, he's not sure of this, and he understands that he does have macular degeneration, however. He's unsure about his renal function, and it will be interesting to see what his creatinine levels are. In terms of his peripheral neuropathy, he does have peripheral neuropathy of the feet with reduced sensation of his forefoot and his toes. His macrovascular complications are significant, including, as mentioned, peripheral vascular disease with what he thinks is femoral stenting of the left femoral artery. He's also had coronary artery disease with coronary artery bypass graft. He hasn't had a stroke or any episodes of transient ischemic attacks in the past. His third issue is his urinary continency, he believes. He's been suffering from urge incontinence for about 3 to 4 years. He describes difficulty getting to the toilet on time, primarily due to his mobility issues as well. His risk factors are his diabetes, which may be resulting in neurogenic bladder, his advanced age, as well as his diabetic treatments for his heart failure. He's on bumetanide and hydrochlorothiazide. In terms of investigations, he does not record any urodynamic studies being performed, and he has had a urine test this admission due to dysuria, which revealed a urinary tract infection. He's on IV meropenem, so I do assume that this is likely an extended spectrum beta-lactamase infection. In terms of management, he used to wear pads regularly for his urge incontinence. However, he was started on meropenem by his GP, which significantly improved his symptoms, and he finds that he does not need to wear pads as often for his overactive bladder. This to me suggests that it's got a combination of a mixed picture of stress and neurogenic incompetence. His final issue is his ischemic heart disease with likely ischemic cardiomyopathy. As mentioned, he was diagnosed with myocardial infarction approximately 30 years ago when he presented with chest pain. At the time, he's unsure whether an echocardiogram was performed, but he did have an angiogram, and that revealed coronary artery disease where he underwent a coronary artery bypass graft. There was no complications to this procedure. He's been managed since with aspirin and also diuretics, including bumetanide and hydrochlorothiazide. He's not on an ACE inhibitor, and he's not on an beta blocker, and I'd like to investigate the reasons for that. This may be due to renal impairment. He's not on a fluid restriction as far as he knows, and he does not measure his weight daily. In terms of complications, there's been no further chest pain or admissions for acute pulmonary edema. He denies any orthopnea or PND, but his exercise tolerance is significantly reduced due to shortness of breath of approximately 100 metres. His New York Heart Association class would be between 2 to 3. His other past medical history includes macular degeneration. He's not on any medications for that. He has osteoarthritis of the hands, which takes paracetamol regularly, and he suffers from reflux, which is on esomeprazole. In terms of preventative medication, he has his influenza vaccine last year. He has not had it yet this year. He has had his COVID vaccination 4 weeks ago with the AstraZeneca vaccine, he believes. He does not undertake any regular screening tests performed by his GP, including a fecal occult blood test. His medications, as mentioned, include diuretics. He's been recently started on cholecalciferol at a loading dose of 50 micrograms 3 times a day, which suggests to me he's vitamin D deficient. Along with, as mentioned, he's on linagliptin for his type 2 diabetes and Rysodec 28 units per morning. He's on also temazepam at night, 10 milligrams, and amitriptyline 10 milligrams at night, possibly for sleeping aid. In terms of his social history, John's a retired steel manufacturer, and in fact retired approximately 20 years ago. He lives on the pension which he's comfortably financial on. He lives alone in a 2-bedroom house, and he's been alone for 11 years since his wife passed away. He has his house fitted with rails and showering aids. He mobilises with a wheeled Zimmer frame and requires 7-day assistance, mainly with administration of his medications with his insulin. He does shower independently, he goes to the toilet independently, he doesn't drive, and every fortnight he has a cleaner come in. His neighbour also, who he has a good relationship with, helps with weekly shopping. He has Meals on Wheels, which is delivered every week as well. And for breakfast, he makes himself toast, and for lunch, he makes himself a sandwich, relying on Meals on Wheels for dinner only. He has one supportive son who lives in Mandurah, and in fact visits him every fortnight and calls him every day. And the plan, after discussion with his son, is that he will move to residential care placement, where he can be closer to him and visit him more often. He doesn't have a very active social life. He just sits in front of watching the TV on most days. His goals of care surprisingly have not been discussed with him, and he has never discussed CPR either. He has a will, and his son is his power of attorney. Mr. Smith understands that he won't be able to cope at home, and that is why he's agreed to residential care placement. On examination today, his blood pressure was 135/60, heart rate was 60 and regular, his respiratory rate was 18, and his saturation was normal. He was afebrile today. I did a brief mental assessment, and his AMT4 score was 4 out of 4. His blood sugars, as mentioned, was ranging between 9.5 to 20.9 over the last 48 hours. Examination of his cardiac system revealed a midline sternotomy scar with permanent pacemaker in situ in the left subclavicular area. His heart sounds were dual, there was no murmur, and his JVP was not elevated. He had moderate non-pitting edema up to his ankles with equal swelling in both ankles. There was evidence of vascular insufficiency with dusky toes bilaterally. There was also evidence of, on the left foot, ulcers in the first and second toe. These were clean and dressed and did not appear erythematous or infected. They were dry ulcers. There was osteoarthritis of his hands as well, with Bouchard's nose detected. Examination of his lungs and his abdomen was unremarkable. His lungs were clear with good entry in the basis, not suggestive of any fluid overload from his possible heart failure. So in summary, John is a 98-year-old man who is undergoing rehabilitation for acute lower limb palliation. His planned disposition will be to a residential care facility where he can obtain regular support. He will, however, require optimisation of his peripheral vascular disease, cardiovascular disease, and diabetes, as well as his mobility, to give him the best outcome with what is expected to be really a limited prognosis given this advanced age. There's 4 main issues I'd like to discuss today. The first is his functional state and poor mobility with his false risk. Number 2 is optimisation of his type 2 diabetes, and in particular focus preventing worsening of his diabetic foot ulcers on the background of peripheral vascular disease also. Number 3 is optimisation of his cardiac function, and number 4 is future disposition planning for him. So I'll start off with his functional state and his poor mobility.
Okay, so we'll talk about the number 1 issue that you've identified. So do you want to summarise for me what risk factors are present in this gentleman?
For his falls in particular?
Falls.
So there's multiple risk factors. One is decondition post this procedure. I'd actually like to know what procedure he had. I did notice that he had a femoral puncture there, and it'll be interesting to see whether he got an angioplasty or ballooning, but he seems to be quite deconditioned from a mobility point of view. He's either got significant other risk factors, one being his advanced age and some frailty there. His diabetes plays a big role in that he's got some peripheral neuropathy in the lower limbs, and he's at risk of hypoglycemia on insulin. He's also got peripheral vascular disease, which put him also at risk. And he's on multiple medications, including diuretics, which can cause possible postural hypotension or confusion and dizziness. I do know he's also on...
Did you check his standing blood pressure?
I did not check his postural blood pressure, no. And that's one thing I think is important to do. He's also on, I should mention, his medication, temazepam and amitriptyline, both psychotropic medications that put you at risk of falls.
Okay. How would you go about addressing the temazepam, for example, as a high false risk medication?
Yeah, so I mean it is a short-acting benzodiazepine, but all psychotropics or benzodiazepines that put you at risk of falls. I'd like to kind of liaise with the GP or see when this was started, when he's had problems in the past, but also address the underlying causes of why he needs to be on with his insomnia. So and maybe approach it in improving his sleep hygiene to make sure he sleeps at a regular time every day. Make sure there's no other medication that can be causing insomnia and other factors that can be contributing to his poor sleep, and that maybe we can wean off his temazepam. He's on also amitriptyline at a low dose, which may be possibly for sleep or for his neuropathic pain. It would be interesting to investigate.
So he's been taking temazepam every night for quite a long time, I know.
Yeah.
How would you go about weaning it?
Yeah, I'd in terms of weaning it, I'd probably consider halving the dose for a week and then just stopping it after that. It is short acting, so and it is only a low dose of 10 milligrams at night. But it is, I think, worthwhile attempting just to halve that dose for at least a week and go from there.
Okay. And what do you think the management approach is for improving his function and his falls risk?
Yep, so I would like to get allied health involved in continuous physical therapy. That would be important for strength and stability training. He needs I think it's important for him to have appropriate walking aids, appropriate shoes as well, given that he's got diabetic foot ulcers and he's got peripheral neuropathy as well. He does also have macular degeneration that puts him at risk again of falls. So just ensure he hasn't had ophthalmology review for quite a while. I'd like to link him in with his ophthalmologist or at least an optometrist to actually ensure he has proper spectacles that will help improve his vision. And then from that also other as well as walking aids maybe. He's going to residential care placement. If he wasn't ensure he has an alarm, which he never had, in case he does have a fall. The other important factor is not just preventing the falls, but preventing complications of falls. So in particular, preventing fractures. And I know he's already been started on vitamin D, and that's great. I'd like to know what his initial vitamin D level. He's on a loading dose, so I imagine it was quite low. Check his calcium status, as well as see if he's had a bone mineral density scan in the past. Maybe he qualifies with his age on bisphosphonate therapy or denosumab if he does have osteoporosis.
Okay, so would you start this gentleman on a bisphosphonate?
Not without evidence of at least osteoporosis. I don't think he will qualify. He's not on any steroid treatment long term, and I don't think he will qualify.
How long do you think you need to take bisphosphonate before it starts to prevent fractures?
Yeah, he's got advanced age, so it would. I think at least 3 months. I don't know the exact literature on when the bone mineralisation process will happen, but I know it at least will be a while before it actually shows some improvement.
We'll move on and talk about his diabetes. Yes. So he doesn't know his glycated haemoglobin. What do you think his target glycated haemoglobin would be?
Yeah, I wouldn't put his target as too high. I don't think you need to, with his advanced age, have very strict control. I think the general rule is whatever, for someone over 70, whatever his age, to probably divide it by 10. So I'd aim for a HbA1c probably 9. Although he's got significant high risk for further micro and macrovascular complications, given his limited prognosis, my main goal is not to have any complications with his diabetic foot ulcers, and the other long-term complications are not so much important for him. His prognosis is going to be probably guided by another cardiac event likely, or possibly a significant infection from his diabetes. So I think if we aim for between 8 and 9, that would be reasonable for him, and with minimising his risk of hypoglycemia with his insulin.
So his control's not perfect in hospital, as you say. He's heading for residential care soon. He's got a bed in the next couple of days. Would you want to tighten up his control in hospital? Yeah,
I think it wouldn't be too unreasonable to possibly switch him to a twice daily. If most of his high reading is reading at night, it wouldn't be too unreasonable to switch him to a twice daily Rysodeg or twice daily Novamix to get a better control in the evening. But again, not at the risk of developing hypos. I'd go very low in the dosing. He hasn't had a history of hypos, which is reassuring, according to him anyway. So it wouldn't be unreasonable maybe to split the dosing up of the Rysodeg to twice daily. And as long as we're aiming below blood sugar level of below 15, I think that'd be reasonable. And making sure it doesn't go anywhere near the 4 or 5 range and easing off them.
Yep.
And I would put him on another oral agent.
If his control remains poor, talk to me about how you would escalate. So you've talked about possibly increasing his insulin. What about his oral hypoglycemia?
I would like to know what his renal function is. It would be interesting to see whether he's got any kidney disease. If he doesn't, he's on linagliptin as the only oral agent, which maybe suggests to me he's got issues with metformin or other agents. If he's got good renal function, I would probably think about introducing metformin into the mix for him if there's no contraindications doing that. And that might also help.
I think his EGFR is about in the high 20s.
Okay, so it's probably not the best for him. I think it's relatively not contraindicated, but not advised for G5 less than 30 for memory for metformin. And then you're really limited in your approach to oral agents after that with the renal function that low. Yeah.
Okay.
And maybe dieting would be also play an important role for him. It would be interesting to see what his diet like is at home. Given that he's going again to a residential care placement, I imagine they'll be putting him on a specialised diabetic diet just to help manage manage the sugar levels.
Okay. Mm-hmm. Okay. And if you were starting him on this linagliptin, what side effects would you talk to him to warn him about?
Yep. So with linagliptin, hypoglycemia is not often a known complication. It can cause possibly issues with his pancreas, because pancreatitis, I believe, is one of the concerning side effects. Nausea can also be a concerning side effect for him. And I don't know of any significant other complications with the linagliptin per se. I'd have to really look it up. Yeah.
Okay. So this gentleman, do you want to talk to me a bit about his cardiac medications? Yeah. You pointed out some things that you were surprised about.
Yeah, I mean, for optimization of his what sounds like heart failure, he's on bumetanide and he's on hydrochlorothiazide, so there is an element of possible fluid overload, whether that's from kidney disease or whether it's from heart disease. Given he's had a previous CABG 30 years ago, I assume he's probably got an element of ischemic cardiomyopathy. First thing I'd like to know what his recent echo result was, if he's had an echocardiogram or any sort of cardiac function test, as well as whether he's had any recent coronary investigations such as the CTCA or previous angio. So I'd like to start from there and see what his cardiac function is doing.
What do you know about bumetanide as a choice of diuretic?
Yeah, it's usually used when they've got furosemide resistance, commonly possibly from end-stage renal failure, or where there's significant gut edema. They usually bumetanide is another option for it. It's also a loop diuretic, just like furosemide. And I know the dosing conversion is 1 milligram to 40, so he's at the moment on 1 milligram in the morning, so it's a relatively low dose. So either we've had allergies to furosemide or we've had furosemide intolerance or resistance, bumetanide's the way to go. And so other than the echocardiogram and the coronary investigations, I'd like to minimise his cardiovascular risk profile. I'm checking what his lipid status is, his HbA1c, his blood pressure seems to be reasonably good.
Would you put this chap on a statin?
With his advanced age, probably not. Yeah. I think in the reasonable guidelines would be if the prognosis is more than 2 or 3 years with a very high cholesterol level, it'd be worthwhile. But I would be surprised if his prognosis is more than that. Yeah.
Sure. Okay.
So I don't think it's going to have too much of an effect on him.
Okay. So I've told you his EGFR. He did have an angiogram and angioplasty.
Yep.
Have you got concerns about this chap, and how would you go about managing him around that period? Yeah, so
for the femoral stenting, for the femoral artery, I would be worried with the angiogram it's going to actually develop worsening of his kidney function if there was dye involved with the angiogram, which there would have been. So he's had a plastic but no stent insertion. Is that correct?
Yeah. Yes,
okay.
Right.
Yeah. So they've reperfused the artery. He's on just one single agent aspirin, which I think is very reasonable, but I think close monitoring of his renal function post the angiogram is important.
There be anything you do pre-angiogram?
Yep, there are possible mitigating things you can do, such as NAC and also IV hydration. Again, with him, you'd want to be careful with the IV hydration because he's on diuretics. And possibly with heart failure. But N-acetylcysteine, I believe, is one of the agents that can be used pre-angio, pre-contrast use. Yeah.
Would you give him NAC?
I'll talk to, I'll liaise with the renal team and also with the radiologist and see what their guidelines are. Yeah, and that might help guide me.
Sure.
Yeah.
Okay. So talk to me about his, so potentially he could have indications for being on a dual antiplatelet.
Yep.
How do you balance that up against?
Yeah, I mean, with
risks?
his advanced age, and given he's also got a history of GORD, you'd be cautious wanting to give this gentleman dual antiplatelet therapy. I believe with his risk of bleeding, he's had no bleeding in the past.
We'll stop there. You're right. I think we're just out of time.
Yeah.